So we will start our lecture series on renal today. And the plan is to talk about urinary tract infections. Hopefully if there's time, we'll also talk about nephrotic and nephritic symptoms as well. Sure, we've all seen quite a number of urinary tract infection cases, being it locum and whatnot. And some of us have actually gotten UTIs before. So symptoms and signs or clinical features of UTI shouldn't be so strange to us. Okay, so we're not going to do anything different. It's just the usual how to be able to make a good diagnosis of a urinary tract infection and how to manage once you make that diagnosis. That's what we are going to be touching on. So at the end of the lecture, I expect that once you are sitting in the consulting room and you have patients coming to you, telling you about features suggestive of a urinary tract infection, you should be able to make that diagnosis and, of course, apply appropriate treatment or management to a diagnosis. Okay. So, of course, what's a UTI? And as the name suggests, we know that the urinary tract system is an organ system on its own. Sometimes it's combined with the genital, so you have what we call a genitourinary system. Once you have any infection along any part of the urinary tract system, and let's say from down to up, because the infection usually tends to be in an ascending manner. So any form of infection along the urinary tracts from your urethra way up to the level of the kidneys, then we say that you have a urinary tract infection. Okay, so urinary tract infection, or for the sake of the lecture, we'll be using UTIs a lot. Or UTI is not just something which is restricted to the lower aspect of the urinary tract. It can occur along any part of the urinary tract. So from the urethra to the bladder to the ureters, way up to the renal pelvis and into the kidneys. If you've got that picture of the urinary tract system, you would know what I'm talking about. We are saying that when you're looking at a male and then a female patient, urinary tract infections tend to be more common in female patients. And that's if you're looking at them in terms of their anatomical structure. So in terms of people who have normal urinary tracts and structures, females tend to get UTIs more than males. In males, UTIs are not so common until about the age of 50. And once they hit 50 and above, they tend to get lots of urinary tract infection. And it's all dependent on the anatomy once they hit that age. A lot of factors come into play, changes in the prostate, the risk of prostate inflammation and prostate enlargement. All these things would predispose the male patient to developing a UTI above the age of 50. And as we go on, we would see other predisposing factors. One key thing is that for females, the urethra tends to be a little bit shorter than in males. So since we're saying urinary tract infection is usually secondary to more of something ascending, the urethra is shorter, then the bacteria or the infecting organism would have a very short distance to traverse before getting to the epithelium or the mucosa of the structure to affect. Okay, so that's the reason why it tends to be more common in females than in males. Okay. If you have a male patient who is young and is getting lots of UTIs, it warrants investigations, more investigations, unlike in a female patient who is coming to you with UTIs. Of course, you'd have to investigate as well, but you'll be more concerned for a younger male patient who is coming in with recurrent UTIs, because most often they have some sort of anatomical pathology which is predisposing them to the urinary tract infection. So once we say a patient has a UTI, then it means that there's significant bacteria in the urine, what we call bacteriuria. Okay, so if you have bacteria in the urine, we call it bacteriuria. And then there are features we look at to say that, okay, this patient has got some form of bacteria in the urine. Okay, so as we go on, we'll talk about that. So if a patient has significant bacteria in the urine, and in that setting, the patient is having symptoms which is directed towards what we call a cystitis or inflammation of the bladder, or a pyelonephritis, which is an inflammation of the renal parenchyma and then the renal pelvis, what we call pyelonephritis. Then we say that, okay, this patient has a UTI. The commonest organism is E. coli. And as we go on, we'll realize why. Okay, we all know that the bowel is full of E. coli. And once you use the washroom, you pass stools and all that, stools contain E. coli. And the rectum is sort of close to your genital area. So sometimes, due to some reasons, you are able to pass some of this E. coli from the back to the front. And once the E. coli gets into contact with your urethra, and then it traverses the urethra, then you'll be at risk of developing a UTI. So there are other organisms which will also predispose you to a UTI. We have other gram-negative organisms like Proteus, Klebsiella, other anaerobic organisms like Enterococcus, which is also found in the GI, and then gram-positive organisms like Staphylococcus saprophyticus, which is common in the elderly, immunocompromised people who tend to get a UTI. Of course, we know E. coli is a gram-negative organism, and it's good. You need to know these things. Your microbiology has to be strong when you are dealing with infectious diseases, because that is what is going to point you to what antibiotic to give. Because if we're saying E. coli are the common causes of UTI, and we know E. coli is a gram-negative organism, then it tells you that, okay, once you make a diagnosis of a UTI, whilst you are awaiting your definite management or definitive antibiotic, you start the patient on something empiric. And this empirical antibiotic would usually be something that would help you manage this E. coli. And that is where knowing whether it's a gram-negative organism helps, because it will direct you to your choice of antibiotics whilst you are waiting your culture. Okay. So I've talked about this, saying infection is most often due to an autoinfection. So from the patient's GI tract, bacteria is transferred to the urinary tract, and then it moves up in the ascending route. Okay. Sometimes you could have other routes like bloodstream transfer. When we say the patient has a urosepsis, you have a UTI and it's that bad that you tend to develop sepsis. Sometimes you could have lymphatic spread. Sometimes you could have a direct extension. If you have an abnormal communication between your bladder and your colon, what we call a fistula, then you can have fecal material moving from the bowel into the bladder. And of course, it's not supposed to be there. So this patient is going to have recurrent infections. Okay. So basically, once we come into contact with this microorganisms, which we say cause UTI one way or the other. But for you to develop an infection, it is actually dependent on the virulence of the organism and the defense system of the host or of ourselves. If the organism is highly virulent, then the risk of you developing symptoms of a UTI is high. And if your immune system is not so strong, also the risk of developing symptoms is high. And the reverse is true. If the organism has a low virulence or the person has a very high host defense system, then you are able to overcome the organism one way or the other, and you won't show symptoms. You're able to write the UTI off, and then you are good. Okay. So when we talk about virulence or an organism's ability to cause infection, what are we looking at? In UTI, organisms that are able to adhere or get stuck onto the epithelial surface of your urinary tract system tend to be very, very virulent. It means they get stuck there, you are making urine, you are peeing, but then you are not getting rid of them. They get stuck there, they replicate, and they get into the cells, and then they produce symptoms. So the ability of an organism to adhere to the epithelial cells of the urinary tract makes it or increases the virulence of this organism. As humans, our immune system is able to activate neutrophils to deal with these organisms. If you're unable to, make this neutrophils because probably your immune system is a bit compromised, then you are going to have issues dealing with these organisms. Also, the urine is made in such a way that the osmolality is high to be able to deal with these things. If you are taking any medication which is affecting osmolality of the urine or affecting your pH, urine pH and whatnot, there it comes a risk where this patient becomes exposed to a UTI. Also, our system makes complement, okay, what we call complement activation with IgA antibodies. We know IgA is usually found in mucosas and all that. So to be able to protect the uroepithelium, if you are not making these things, then you are actually in trouble when you are exposed to virulent organisms that cause UTI. And then our body naturally has some sort of antibiotics, what we call the natural flora. Okay, our body has bacteria, what we call the natural flora, and this natural flora plays you can say an antibiotic or antibacterial role, even though it's there. It prevents the overgrowth or it prevents other bacteria from taking over. And once this commensal organisms which sorts you out becomes depleted, then you will develop a risk of UTI when you are exposed to this virulent organisms that we are talking about. If you keep urine for a very long time and then you don't urinate on time, you tend to keep urine, that's stasis. And this urine stasis would put you at a risk clearly, because once the urine is not being passed, it stays in one place. It's just like picturing peeing in a chamber pot and leaving it in a room for a very long time. When you come back, you realize that the whole urine has changed. The whole place has become very stucky. The smell is that bad. Sometimes you see foam all over the urine. It tells you that once you leave urine in your bladder for that long, there's actually a risk of bacteria colonizing the urine and putting you at risk of a UTI. Okay, so risk factors, urinary stasis. So this could actually be one of the reasons to why UTIs are more common in women, because we know that, we the men, we can just stand anywhere and pee, but women, once they are out, they would have to keep their urine for quite a very long time until they get a suitable place to pee. And that actually puts them at risk, because we are talking about urinary stasis. The other thing is if they just go and pee anywhere to where it's unhygienic, it actually puts them at risk as well. So it's like the devil in the deep blue sea. And of course, that will put them at risk. Conditions like diabetes, we know affects the immune system, the sugar and all that. There's a risk of urinary tract infection. Pregnancy also will put you at the risk of urinary tract infection because the immune system changes. And then once the pressure in the abdomen is increasing, baby's head is pushing down on the bladder and whatnot, then it's easier for organism to traverse because it's like the bladder and the urethra comes down just a little bit more. Organisms are able to traverse easily, and then infection can take place. If you have congenital abnormalities of the urinary tract, which will predispose you to urinary stasis, clearly you're at risk of developing a UTI. Instrumentations, catheterizations of the urinary tract system would also put you at risk of developing a UTI. If you're immunosuppressed, we've talked about that. And then sometimes, or in fact, once you hit your menopausal age, your defense mechanism sort of drops a bit. The same for males. We are saying that once they reach 50 and above, changes in their anatomical structure will predispose them to developing a urinary tract infection. Okay. So always, when you have a patient who is coming to you with clinical suggestive of a UTI, you need to take a detailed history. You need to rule out other things. You need to find out, is this just a UTI secondary to, just the normal exposure and all that, or this patient is actually immunosuppressed. That's why there's a UTI, okay? So you need to take a detailed history. You need to ask the patient, so have you had any catheter in situ recently? Sometimes you'll be on the ward, you've done a surgery for a patient who has got a catheter in there, and then remove the catheter maybe after a day or two, because probably the patient wasn't making enough urine, so he decided to keep the catheter in for some few hours, a day or two after surgery. And when you take it out, maybe within 24 hours, the patient starts telling you that, when I urinate, I feel there's pain. You should draw your attention to the fact that probably you might have a urinary tract infection on your hand, and not just maybe you passing your catheter has damaged the urethra. It could actually be a UTI you are dealing with. Sometimes people go like, oh, it's the catheter. We just passed it and probably it's injured the urethra, so it would heal. Don't worry. The catheter in itself predisposes this patient to developing a urinary tract infection. So once your patient tells you that, then it means you need to try as much as possible to go further in terms of history taking, examination, and then investigations, okay, to be able to ascertain the actual cause of what the patient is talking about. Okay. Of course, a patient who is coming to you with recurrent clinical features of UTI also warrants investigations, because why is it recurrent? There's actually a reason why this is recurrent. So we need to find out why. What are these clinical features that I'm talking about? So we're saying once the urinary tract infection is restricted to the bladder, we say that the patient has cystitis. Okay. If it goes way up to the ureters, then we have the ureters being involved. If it goes way up past the ureters to the kidneys and the renal pelvis, where we say the patient has pyelonephritis, then it tells you that it's more serious than a cystitis, okay? Because pyelonephritis can actually lead to some form of acute kidney injury, acute renal failure. And people have had very bad pyelonephritis and haven't recovered fully. And it's actually led to some form of chronic kidney disease if you don't manage it well. And then you end up developing not just a pyelonephritis, but you develop pus in there and all that. Or we call that what? A pyelonephritis, or those things. Or maybe there's some form of obstruction there, which is predisposing this patient getting infection. And this obstruction is also preventing urine from passing down to the bladder. So you have what we call hydronephrosis, because urine is being made, stays stagnant in the kidneys and all that. This can actually lead to kidney damage, which can be very critical. So yes, one main feature the patient will tell you about is dysuria. In fact, that's like one of the commonest features. The patient tells you that when I urinate, there's a burning sensation, then that should be pointing you to a urinary tract infection. Okay. And this dysuria would usually mean that there's some sort of inflammation in the urethra. Okay. You could also have frequency where you are peeing a lot of the time. And how do we assess frequency? Usually you ask the patient, are you urinating a lot? And most of the time the answer you get is, oh, well, of late I drink a lot of water, so I'm peeing a lot. That is actually not so objective enough. So it's actually good to ask the patient. Ideally, we expect that within 2 hours, you want to pee once. People who have frequency tend to pee more within 2 hours. So you can ask the patient, oh, in the space of 2 hours, how many times have you peed? The patient will tell you that, oh, I haven't peed at all. Okay. It doesn't rule out a UTI, but at least it tells you that there's no frequency. Now the patient tells you, I have pain when I urinate, in the space of 2 hours, I've peed like 2 to 3 times, then clearly it's actually pointing you to a urinary tract infection. Okay, so you need to investigate further as well. Then the urine may be cloudy depending on the severity of the infection. It would come with a very, very funny smell or a malodorous smell. Sometimes you can see blood in the urine, what we call hematuria. The patients can have pain in the suprapubic region. That's where your bladder is. Pain can be up the abdomen. Pain can be by the flanks when the kidney is involved. So once you have flank pain and then you examine, you touch, and it's very tender, or you do, you try to hit the back of the loins, okay, what we call, you're trying to elicit renal angle tenderness. So you try and make a fist and then you gently hit the patient's back where the kidneys are lying, what we call renal angle tenderness, eliciting renal angle tenderness. Once you hit and the patient moves or the patient winces and tells you there's pain, then clearly there's renal angle tenderness, and that's will point to pyelonephritis, inflammation of renal pelvis, and the renal parenchyma itself. Of course, UTI, just like other infections, will come with constitutional symptoms like fever, headaches, vomiting, nausea, chills, general body pains, all of that. It's usually more severe if we are dealing with UTIs in the upper aspect of the urinary tract infection. That's the pyelonephritis. Okay. That tells you that if you have a patient who has a cystitis and you have a patient who has a pyelonephritis, management for the pyelonephritis would be more aggressive because that one is high up, and the kidneys, if you don't manage it well, you are going to cause complications for your patient. So investigations, we do very basic investigation like a urine dipstick, or you can do a urine routine examination or microscopy. And then it's always good to do a urine culture, because once you've said there's an infection, you need to know the organism causing the infection. Okay. So usually once you do a urine dipstick and then you're able to pick up leukocytes in the urine, that should be pointing you to a urinary tract infection, leukocytes or white blood cells in the urine. Okay, should be pointing you to a urinary tract infection. Okay, so most of the time when you are dealing with a cystitis and then you examine the urine, you are likely to find about 1,000 colony forming units, what we call CFU, colony forming units per ml of urine. If you are dealing with a pyelonephritis, which tends to be more severe, you usually find more than 10,000 colony forming units. This colony forming units, you're talking about the bacteria colony, okay? per ml of the urine. And then in some situations, you could actually have very, very, very high amounts of bacteria in the urine, but this patient wouldn't be showing any symptoms at all, what we call asymptomatic bacteria. So you have high amount, about 100,000 or more colony-forming units of bacteria in the urine, but then patients wouldn't be showing any symptoms at all. So you basically pick up this one when maybe patient has come to you for a general exam, you are checking the urine, or maybe patient has come with some form of headache, fever, joint pains, but no urinary tract symptoms. You are thinking this is malaria, but then of course, you know UTIs can cause constitutional symptoms. Even though this patient is not giving you any classic symptoms of a urinary tract infection because of the fever, headache, chills, which is non-specific, you just decided to do a urine RE. Then it comes back and tells you that patient actually has about 100,000 colony-forming units. So this patient has a urinary tract infection or bacteria in the urine, but it's basically asymptomatic. Classic UTI symptoms are not there. Okay, and that is one reason why we always say when patient has febrile illness, at least do a full blood count, blood film for malaria parasites, and a urine RE at least. It would help you make a good diagnosis of your patient. Okay, so there's also a role for imaging study, and this is very essential because, as we said, especially in males, once they have UTIs and it's recurring, then it tells you there's a problem somewhere. So you need to do an imaging study to find out if the anatomy is intact. You can do an abdominopelvic ultrasound scan. You can visualize the prostate to see if probably the recurring UTI is because prostate is big, maybe BPH or maybe chronic prostatitis or something of that sort. Okay, the abdominopelvic ultrasound scan can also visualize your kidneys and tell us the state of your kidneys, can tell us if you have any water in the kidney, hydronephrosis, pus in the kidney, all those things. It can actually tell us. Severe cases, you can do an abdominal CT scan if maybe the patient has a symptoms suggestive of CA of the prostate or cancer of the prostate with recurring UTIs. Abdominal CT will also show you areas of metastasis or spread of the infection and all of that. I can do an abdominal MRI scan as well. So imaging study comes in handy, especially for male patients or for general patients who have recurrent UTIs. You want to know the state of their urinary tract system. Complications, you could have recurrent infection. It could be that severe, the blood can become infected, or we say urosepsis or sepsis, which is secondary to a very severe urinary tract infection. You could have a permanent kidney damage, as I've talked about. You could have pus in the kidneys, water in the kidneys over there, as we talked about, pyonephrosis, hydronephrosis. And then you could form a fistula, because if you have recurrent infection or a very bad infection, it damages the mucosa. It could connect to another organ space and form a fistula. It can also connect to the surface of the skin and form a sinus, okay, which would even increase your risk of getting further infections, because once there's an abnormal communication, every now and then you have things getting into the wrong places, and then you are going to be in trouble. So management, there's non-pharmacological and pharmacological. Usually, once you are in the clinic settings, we do pharmacological, but you need to counsel the patient, drink enough water. They should try as much as possible to pee when they have the urge to. Cranberry and then blueberry juice also gives some protection to the mucosa, and then, prevents this addition of virulent bacteria and all that. So it's good. When you use the washroom, you have to make sure that you are not wiping from the back to the front. Okay, you do vice versa. The female should try as much as possible to avoid irritating feminine products, because this will breach your urinary tract mucosa down there and will predispose you to getting UTIs. Because once the mucosa is breached, bacteria can enter easily. Then, of course, pharmacological key, we do antibiotics. And these are antibiotics. As I said, it will be dependent on what we think is causing the UTI, whilst we take sample and wait for culture to come to tell us what is actually causing the UTI. So it's what we are suspecting versus what is actually causing it. And once you're suspecting, you don't just take sample and say, well, let's wait for what is actually causing it. No, it's a wrong practice. And that's why we need to know about gram positives, gram negatives, anaerobes, all those things. And we also need to know the common organisms that we find in UTIs. And clearly we're saying E. coli tends to be common. E. coli is a gram-negative organism. So you need to select an antibiotic which is suitable for gram-negative and suitable for the patient. I'm saying suitable for the patient because you can have two female patients. One is pregnant, one is not pregnant. And we know medication like ciprofloxacin is very, very good for gram-negative organisms and UTIs. At the same time, we know cefuroxime is also very good. You have to make a decision because once the patient is pregnant, you wouldn't want to give the patient cipro because of what they say about risk in pregnancy, babies, and whatnot. And then you would rather want to choose your cefuroxime for the pregnant woman because that's the practice, that's what we do. And then you give the cipro to the non-pregnant woman. Or a patient who comes and tells you, I react to cipro, you wouldn't want to start your empiric treatment with cipro. You would want to give something else that covers gram negative, whilst you await your culture and sensitivity. So it's key. When your culture and sensitivity comes, it will direct you and it will tell you, this is the organism, use this antibiotic. Klebsiella is the organism, let's use this. Staph saprophyticus is the organism, let's use this. So it's always key. You don't just take a urine RE or do a urine dipstick and you cross your leg and you are just there. You put your patient on cipro and say, go home. Patients will go and come back again, even though we are thinking E. coli is the commonest cause. What if the E. coli this patient has is actually resistant to cipro because the patient has been taking cipro for a very long time? It's always good to do a culture and sensitivity because you could actually diagnose cipro or any gram-negative, you could diagnose E. coli or any other gram-negative organism in the urine, but then it will tell you that you can't give cipro. Cipro is resistant, probably because the patient has been taking it for a very long time, or this kind of gram-negative organism, this one that the patient has picked up is resistant to cipro. So culture and sensitivity, always do it once you make a diagnosis of a UTI. In cases where the temperature is high, you have to give antibiotics. In severe cases, we're saying patients who are immunocompromised, are diabetic patients, are elderly patients. These people need a critical look at. So you have to ideally admit them, do IV antibiotics for them, and then give them enough fluids so that they don't go into any form of shock as well. Young patients who are vomiting and cannot tolerate orals, or fit patients who are vomiting and cannot tolerate orals can also be put or should also be put on IV antibiotics until vomiting ceases, and then you go ahead and then you switch to orals. Of course, once the patient is vomiting, you want to add an antiemetic to your treatment. So, as I said, antibiotics, so the effective therapy against gram-negative organisms, you can see it there. So, can give the fluoroquinolones, so cipro, fluoxacin, levofloxacin, moxifloxacin, they are all fluoroquinolones. You can give, of course, they have different generations. So depending on what you're dealing with, you give accordingly. You can give your cephalosporins, which is cefuroxime, cefaclor, cefixime, ceftriaxone for different generations. Okay, your cefuroxime and cefaclor, usually second generation, your ceftriaxone, third generation, and cefixime as well. So these are what you can give. Can also, the culture and sensitivity report, you can put your patient on nitrofurantoin. But some of the organisms are so stubborn that you need to use uncommon antibiotics or antibiotics that are not commonly in use currently for UTIs to manage them, like nitrofurantoin and then Septrin, which is trimethoprim sulfamethoxazole. So I think that's it for UTIs. Try and read more about it. At least you have the idea, the etiopathogenesis, the host immune response, clinical features you're supposed to look out for, investigations. Always look at the case you have. Make sure you're doing a culture and sensitivity imaging study, especially for male patients or the general populace who have recurring UTIs. And then if you're also suspecting that the UTI is causing some renal damage, imaging study comes in handy. Okay. And then, of course, management. So I'll take your questions and then we will.
Okay.
Yes, please.
Please, because of the renal involvement, if you think the person may have pyelonephritis or something, will you recommend that we go ahead and do maybe EB and creatinine? And then when you are looking at the urinary,
Yes.
you may have epithelial cells with some numbers, and then the pus cells, and then you don't have bacteria in the urine.
Okay.
Sometimes which is suggestive that the person may be having an infection, but yet there's no bacteria in the urine. What do you do?
Okay. All right. That's good. So yes, so the first one, of course, once you're suspecting renal involvement, you need to do a BE and creatinine. Okay. Especially for patients who you'll be managing for recurrent UTIs, you need to request for a BE and creatinine. And of course, you need to request for your imaging study so that you know what is happening. So yes, you can add that to it. When you do a urinary, you are looking out for leukocytes, you are looking out for pus cells. Sometimes I see urinary reports, you can see they write bacteria 1+, bacteria 2+ on the same urinary report. The thing is that your main focus is on whether you have leukocytes in there or not, or whether you have pus cells in there or not. Okay. So usually for females, because we are saying UTIs are common than in males, you need to see some sort of a higher number of pus cells in a female before you'd want to say the patient has a UTI. So in females, we usually use the number 10. If you have more than 10 pus cells in the urine, you have to manage the patient for a UTI. Okay. If there's leukocyte 1+, 2+, 3+, you need to manage the patient for a UTI. If you do a urinary for a female patient, there are no leukocytes and pus cell is around 8. You don't have to worry. It's not like a UTI unless a patient has clinical symptoms, evidence of a UTI. So you tell you that, okay, pus cells are now building up. Okay, so let me just start managing. But if you are not sure, patient has maybe fever, joint pains, headaches, non-specific symptoms. You've done a urinary, leukocyte is negative, no even trace, negative, and pus cell is like 6 or 7. You don't need to manage this patient for a UTI. However, in a male patient, pus cell above 5 would warrant management, okay? Because we are saying it's not so common in males. So when the pus cell levels are, you have your threshold for instituting treatment for male patients based on pus cells. You need to give yourself a very small threshold. Once you are having pus cell 6, 7, you need to diagnose a UTI and manage your male patient. So that's where the pus cells come in. We usually don't use epithelial cells in managing UTI. Epithelial cells just tells us that maybe you are shedding a lot of your, the epithelium out and it's coming in the urine. It could be a UTI, but if you don't have pus cells in there or you don't have leukocytes, it means there's actually no bacteria. So we would have to find the cause of the epithelial cells, but we won't classically institute management for you just based on epithelial cells. Okay, are you okay? And then one last one, the bacteria 1+, 2+, 3+ they write on a urinary report, it's not enough for you to start treatment of a UTI. Why do I say that? You see a patient who is pregnant and tells you she's peeing frequently. So that's like frequency, but pregnancy in itself, because the uterus is sitting on the bladder, they tend to pee frequently. Now, you are not sure whether you are dealing with a UTI or pregnancy-associated urine frequency. So you go ahead and do a urinary. Urinary comes back and it tells you leukocyte is fine, parcel is fine, and then it writes bacteria 2+ is there. This clearly tells you that the bacteria 2+ is over there. It's not really coming from the person's system or in the urine. Probably it's coming from an external contaminant. Whoever is doing the lab might have contaminated the sample. You don't just base on bacteria 1+, 2+ that you see on your urinary report to treat the patient. No, you don't base on that, because even the lab people will tell you that this bacteria may be due to an external contaminant or extraneous contaminant. That's if you go to those high time, big time labs. Okay, so it's not enough to just manage your patient. However, when you do a culture and sensitivity and it comes back and it tells you that there's bacteria in the urine and this bacteria is pathologic, then you go ahead and manage. But if it's just a urinary derived bacteria 1+, 2+, because we see it a lot, but leukocyte is negative, parcel is below 10 in females, below 6 in males. Don't stress your patient managing for UTI unless they are classic symptoms. Okay. Are we okay?
Yes, sir.
All right.
Hello, sir.
Yes, Esther.
Sir, please, with the rehydration aspects, since the patient is, already urinating frequently, is it advisable for the patient to take in more fluid?
Oh yeah, it is, especially for your elderly patient. The frequent urination is not a bad thing.
Okay.
It's not a bad thing once they are on admission, because you remember we said that stasis of urine is rather the bad thing.
Yes.
So if they are not peeing frequently, then it means the urine is going to stay there. Risk of infection goes up. So it's not a bad thing. You are hydrating because it can get bad, especially for your elderly patients and whatnot. They can go into sepsis, and sepsis will lead to shock. You need to hydrate the patient. Okay.
All right, thank you.
Okay.
Hello, sir.
Hi.
Yes, sir. My question is, you made a patient, you suspected UTI, the patient did some labs, and there's blood in the urine, but she is not in her menses. What further tests do you do?
Once you find blood in the urine.
Yes, please.
So once you find the blood in the urine, your urinary itself that you've done should provide a basis for diagnosing the blood in the urine. Sometimes once you find blood in the urine, then all the differentials will start coming up. Why is there blood in the urine? Is it just because of the UTI? That's one. Or is it because nephrotic syndrome or nephrotic syndrome, which we'll be talking about shortly? Or is this patient having some sort of stones in the urinary tract, which is peeling off the inner aspect or the lumen of your urinary tract, and hence you have red blood cell cast and whatever coming out, you have cast forming, and then you have blood in the urine. Your urinary will show you all that. So if you take a look at the urinary, you can see all those things there. Okay, sometimes you also do it and the patient is menstruating and you see blood in the urine. So causes of hematuria comes in is a lot. If it's schistosoma, because you are doing a urinary, they do a microscopy. If it's schistosoma, they can actually find over and it will be documented on the urinary report. So that's actually a basis for you there. Okay, if you are not convinced and you think that there's more to this, then of course it warrants further investigation, and that's where the imaging studies will come in, so that you can actually take a look at what is happening, where the blood is coming from, what is causing the blood and whatnot. Are you okay?
Yes, doc, I'm okay. Thank you.
Yeah, you're welcome. If sometimes that's severe, there's massive hematuria, patient is bleeding actively, of course, you want to check your HB and be sure your patient is not getting anemia secondary to severe hematuria. If it's a male patient where the prostate can sometimes become cancerous, and once it becomes cancerous, one of the features you see is hematuria. Once you see that in a patient, and the patient has UTI and all that, as I said, it warrants further investigation. You need to do imaging and take a look at the prostate and see if the prostate is cancerous, or because a patient can come to you with UTI hematuria, male patient about 40, UTI hematuria. You go ahead, you do your urinary, you do culture, you do imaging studies, and you end up finding out that the prostate is actually cancerous, and that is what is causing the hematuria. So these are the further investigations that you can do. Yeah.
Okay, thank you, Doc.
You're welcome.
Hello, sir.
Hi. Hello.
I read elsewhere about using. Hello.
Yes, I can hear you, please.
Hello.
Hi, we can hear you.
Okay. Elsewhere about using. Okay. I read elsewhere about using two reproductive genes to determine whether the infection is complicated, UTI, or uncomplicated UTI. How credible is that?
I didn't hear a lot of what you
So I
said.
didn't hear the question.
Yeah,
So
I'm
let's
saying
try
that.
again. If your network doesn't work, then you can type it out. So let's try one more time.
Okay. I read elsewhere about using this in age group and reproductive group to determine whether the infection is complicated or not complicated.
Okay, you said you using what? You said using what? Age group and reproductive group.
Yes.
Okay.
Find out whether it is UTI or uncomplicated.
Okay, to find out if the urinary tract infection is complicated or not complicated.
To determine whether it's systemic or localized.
Okay. Okay. I get what you mean. Hello.
Hello, we can hear you.
I think
Yes,
his
so
network is
his
bad.
network is not so stable. But then I get what he's saying. So it all depends on the risk factors which we've talked about. So of course, increased age would put you at a higher risk of developing a severe disease. So it all boils down to the risk factors. I'm pretty sure there are a lot of studies that they've done, and then they try to structure risk factors in terms of UTI, and one could be what he's talking about. So once the age is advanced, then clearly, you have a risk of stasis being a male patient or female patient and all that. As you grow, the bladder strength wouldn't be as it used to be when you were young and all that. So you tend to store a lot of urine in there. Stasis predisposes you to urinary tract infection. So yes, so the age group, it puts you at a risk, okay? And then as you are old, once you get the infection, because your immune system is most likely your infection will be severer as compared to the younger person. So you can actually use the age to predict the severity, okay? But then it's not enough. You need to see the signs and symptoms to make that diagnosis that this is severe UTI or urosepsis, okay? So the age can help you predict. And as I said, that will affect your management. So during the management, remember I said that elderly people, diabetics, immunocompromised, once they have a UTI and you are managing them, you need to try and then hit them hard. Possibly you can admit, give your IV antibiotics, because you are suspecting that if you don't manage these patients well, you end up messing them up really. And because they are elderly to their renal function, sometimes it's already a little bit impaired. So if you don't manage it well and the UTI goes to mess things up there, then it means patient management wouldn't be so good. Okay, so yes, you can use that to, determine how to go according to your management.
Hello, sir.
All right. Yes.
Well, can some of the family planning devices cause UTI?
So family planning devices. So example.
Like the one they insert, is that spermicide or what is that? I've forgotten the real name.
IUD.
It's not IUD. There are some tablet. I don't know what it's tablet. They inserted it, it will melt there before that one will kill the sperm or something like that.
That is contraceptive.
Spermicides.
So like the spermicides and the foaming creams. Yeah, so ideally it shouldn't cause a UTI because you're putting it in your vagina and not the USR. Are you okay with that?
Yes, sir. But in terms of investigation, can you also use a urodynamic?
Oh, yes. So you can use that, and that will be dependent on other things. So you don't do a urodynamic study for your usual urinary tract infection. If the urinary tract infection is secondary to something else which is causing an obstruction, then you would want to do further investigation, not just for the urinary tract infection, but for whatever is causing the obstruction. Do you get it? Hello?
Yeah, hello, sir.
Uh-huh.
Hello.
Yes, hi.
Yeah, sir. I want to find out if a woman is on her first trim and is having a chronic UTI, what would be the best choice of drugs to use?
Okay, so best choice of drug would still be dependent on your culture and sensitivity. That is the best choice of drug, culture and sensitivity results. And when it comes, then you will determine if this medication is safe in pregnancy or not. However, if you haven't done your culture and sensitivity and the question you are asking, you mean to say that what is the empiric antibiotic of choice whilst you are with your culture and sensitivity? Usually we go for the cephalosporins instead of the fluoroquinolones. Okay.
Okay. Thank you.
You're welcome. Okay, so let's move to the next topic.